Hello and welcome to our live stream, Exploring the Roots of Addiction Risk. I'm Ed Bottomley with the Michigan Medicine Department of Communication. Today, we're going to be talking about the current state of understanding of substance use and addiction, including the risk factors that can increase the chance that a person exposed to drugs or alcohol will go on to problematic use of these substances. We'll explore the current state of knowledge and also what we know about how to treat substance use issues with care that's based on solid medical evidence. This is the second of 4 live streams we're doing on mental health topics as part of Mental Health Month. Today's panelists include 2 faculty from our Department of Psychiatry and Addiction Center, both of whom are trained as clinical psychologists and do research on substance use and addiction. Dr. Mark Ilgen is director of the University of Michigan Addiction Treatment Services, which offers outpatient and telehealth-based care for youth and adults with substance use issues. He also oversees adult addiction research at our Addiction Center and has a special focus on veterans as part of the Center for Clinical Management Research at the VA Ann Arbor Healthcare System. Dr. Alex Weigard is an assistant professor of psychiatry and did advanced training in addiction at our Addiction Center before joining our faculty. He has a major research project underway to look at data from large groups of teens and young adults to identify specific risk factors that might put young people at highest risk of future problems if they use drugs or alcohol. Now, before we start, just a few housekeeping items. You can submit questions at any time for our panel to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video, but please note that if you do that, your name or profile name will be visible to others participating. If you prefer a more anonymous option, you can send a private message to us via ask-mishmed@med.umich.edu. One more time, that's ask-mishmed@med.umich.edu. If you can't stay for the whole chat or want to share the recording with a friend, a video of the chat in its entirety will be available on our Michigan Medicine YouTube channel. That's the place to search for it if you're looking for anything there. So let's move on to our questions for today's live stream. I'd like to start with something pretty basic, the language that we use to talk about drugs and alcohol, and specifically about problems that arise for some people who use them. We hear words and phrases like addiction, substance use disorder, drug problem, and dependence, and alcoholism, and hooked. And they don't all mean the same thing to every person. Could you perhaps take a moment to talk about what some of these terms mean?
Sure. Thank you for the question and for the opportunity to talk with everyone today. I think when you're talking about substance use and addiction, it's helpful to think about 2 domains that are separate but related to one another. These are, 1, how much a person is using. Here we're talking about the quantity and frequency of use. Many times when we hear from someone where they're concerned about themselves or a loved one, they express concern just about the sheer amount of a substance that someone seems to be using. The second domain relates to problems associated with use. And here we're talking about consequences. And when treatment providers diagnose and provide care for a substance use disorder, they're actually talking about the problems that someone has related to substances. So to diagnose someone with a medical diagnosis of a substance use disorder, clinicians often use what's called the DSM. And according to DSM criteria, there are 11 criteria that someone, or symptoms that someone can report to meet for having a substance use disorder. These are things like wanting to cut down or stop using a substance, but not being able to do so, experiencing craving, experiencing different consequences from use. And these symptoms occur on a continuum, and the individual is diagnosed with a substance use disorder that can range from mild to moderate to severe. And two of the specific symptoms that people can report relate directly to what you often hear when people say addiction or hooked. These are tolerance or needing more of a substance to get the same effect that you used to, or withdrawal, experiencing either physical or psychological symptoms when you go without a substance. So when I say these are separate domains, I mean that some people can be high in terms of the quantity of substance they use, but have few or no symptoms. Other people use comparatively less of a substance, but have a lot of problems. And sometimes problems can occur without any tolerance or withdrawal or anything that looks like physical addiction. And sometimes those are present. So all in all, it can be complicated, but in general, the more that you use, the more likely you are to experience problems or consequences. And for people that are looking to change their use or showing up to a treatment program, usually the conversation starts with getting an understanding of the problems they're experiencing, and then looking at how changing use or reducing or stopping their use could decrease those problems. And then more broadly, what are other ways that they could be supported or helped to improve those problems?
And I think Mark gave a pretty great overview about those terms, and there's only one thing that I would add, and that's that it's very important to often consider the degree of stigma that's actually associated with each term, because that can vary pretty widely. So oftentimes you'll hear terms like alcoholism or substance abuse, and the problem with these is that these are often felt to be pretty stigmatizing by individuals with substance use disorders and their families. So these words can make people think of some pretty negative stereotypes about individuals who struggle with substance use and problems associated with substance use. And sometimes, when people are trying to get help, they'll say that they've kind of heard about what an alcoholic is, right? And that they're struggling to kind of understand where their own problems fit in with that concept, because they might have a very kind of an overwhelmingly negative or stereotypical view of what that word means. It can be a kind of a difficult concept to relate to and sometimes kind of interfere with getting help. So recently, the field has kind of started to move past stigmatizing terms like that, and also has tried to have a broader discussion about what kind of terms we can use that both accurately reflect, the kind of problems that people face with substance use disorders, and avoid stigmatizing people or relating to those stereotypes. So there's kind of been a lot of discussion of terms like problematic substance use, harmful alcohol use, et cetera, just kind of as Mark pointed out, highlighting that, basically it's the combination of substance use and experiencing problems, and kind of referring to those problems in a way that isn't stigmatizing or reinforcing of certain stereotypes.
Thank you both for that. Let's move on to our second question. We also want to start out this chat with a very important statement that addiction is, at its core, a chronic disease with physical roots in the brain and genetics, and links to what we experience throughout our lives, and that some people are more likely to develop this disease than others. But it hasn't always been viewed this way, correct? What was changed about our understanding?
Yes, so that's absolutely right. So our understanding of the roots of addiction has constantly been evolving. It actually continues to evolve over time as the science progresses. So historically, addiction was often viewed as sort of a moral failing or as simply the result of poor willpower. This is a pretty dominant view kind of well into the last century. And over the past 100 years or so, what's happened is that we've learned a lot more about how the brain works using, through the advent of a lot of different technologies and the progression of neuroscience as a field. We've also learned a lot about genetic influences on the development of brain systems that might relate to behavior and to mental health. And we've also learned a lot about the effects of substances themselves on neural functioning. And so the kind of main thrust of a lot of these different research programs is that there's been a really dramatic shift in perspectives, both in the medical and the scientific communities, that have really highlighted biological factors that affect risk for substance use disorders and also relate to the persistence of them. So whether or not somebody is able to recover and how. But it's really important to note that this evolution really continues to this day. And one example of this is that even though kind of the dominant medical model of substance use disorders tends to view them as brain diseases, we're learning that although genes and brain systems might cause someone to have greater risk for addiction, we also know that biology is not destiny, right? So there's a lot of different factors that can occur in terms of people's exposure to the environment, their life history, their personal circumstances, and even broader systemic issues in society, things like access to treatment, things like exposure to certain environments or socioeconomic statuses, right, that can actually determine whether or not somebody develops a substance use disorder and whether they can ultimately recover. And so it's important to remember that even though some people might be at a higher risk because of their biological makeup, the vast majority of people who have a substance use disorder are actually able to recover. One of the most interesting things that we've really learned a lot about the brain more recently is that the brain has this remarkable feature called neuroplasticity. And this is the ability to reorganize itself in response to changes in behavior or changes in circumstances. And this is really important to keep in mind when we're talking about substance use disorders, because in this way, when people recover from substance use disorders and engage in treatment for substance use disorders, we know that they're literally rewiring the physical connections in their brain in an important way. So the bottom line is that we know that biology is important for the development of substance use disorders, but it's also really important. It also kind of mediates people's ability to recover from them as well.
Yeah, and just to echo Alex's comments, hopefully our knowledge of the biological underpinnings of substance use disorders helps give us as a society more empathy for people who have substance use disorders and can reduce stigma. And I also think that, again, as Alex was pointing out, this understanding of biology helps us understand the ways that the brain changes with treatment and which treatments could be more useful for whom. So just like there are biological factors that differ in terms of each individual's risk for the onset of addiction, there are factors that can point the way to what might be a particularly useful or beneficial treatment for different people. And over time, we've gotten better at identifying the specific match between people and our treatment options. And I'm optimistic that science will continue to evolve over time.
Thank you. Thank you both for those answers. Let's move on and let's get down to the nitty gritty. Do we know why some people are able to drink alcohol or use a substance occasionally and not develop a problem, but others cannot? What explains different levels of susceptibility to addiction from person to person? Dr. Weigard, you're studying huge amounts of data from studies involving thousands of young people to try and get at this important question. Perhaps you'd like to start with this.
Yeah, absolutely. And this is a great question. One of the most important things to keep in mind is that substance use disorders, similar to a lot of other mental health disorders, as well as actually most physical health conditions, are what we in the scientific community like to call multi-determined. And by that, I mean that there are many, many different factors across the whole spectrum, all the way from a person's genetics or biology, all the way to different life experiences, like we talked about in the answer to the last question, that can contribute to a person's risk for addiction. So it's important to remember that there's never a single cause for somebody developing a problem with substances, in the same way that a lot of kind of physical health conditions like cancer and diabetes, right? You can think of the fact that there also seems to be this pattern of genetic risk, but there are also certain environmental factors that can kind of tip somebody over into having a condition like that. So what we know from a lot of existing research is that there are certain genetic variants that might predispose someone to developing an addiction, as well as the functioning of certain brain systems. So one of my interests is studying brain systems that are involved in things like decision-making, evaluating possible rewards and consequences. And so there is some research that suggests that individual differences in the way that those brain systems work might relate to risk for addiction. But we also know that at a functional level, some of the best predictors that we actually have to do with a person's life history. So in other words, whether or not a person has experienced trauma, does somebody have other mental health conditions? Things like the availability of substances in the home as somebody's growing up or in the community that they're in. a lot of these kind of life history factors can also determine risk for substance use. And there's a real mix of them. So what our research group is trying to do now, and I'm really excited about, is actually take advantage of a couple of large data sets, like you've mentioned. So both there's a study called the Michigan Longitudinal Study that's over 3 decades old. It's been going on at Michigan State University and the University of Michigan, where it basically followed a bunch of folks who were had a family history of alcohol use disorder and were at high risk of developing the disorder themselves. So it followed them over time, took a lot of different measurements in terms of demographic, but also neurocognitive and family history factors. Another great data set that we're starting to work with is called the Adolescent Brain Cognitive Development Study, or ABCD study. So this is an unprecedented study that the University of Michigan and about 20 other sites around the country are taking part in, where they're collaborating to collect about 10,000 kids who are in middle childhood and actually follow them through their adolescence into their young adulthood. And they're basically taking genetic data, brain imaging, a lot of cognitive data related to some of those brain systems like decision making that I've been talking about, as well as a lot of different demographic factors and personality traits. And what these studies give us the opportunity to do is use newer statistical methodologies to basically combine data from all these different levels of analysis and put them into a big statistical model to try and make predictions about an individual youth's risk. So that's kind of the goal. In the same way that an actuarial model used by an insurance company might be able to predict the likelihood of a claim in a certain case, we want to be able to kind of try and build models that are reasonably accurate in predicting whether or not somebody might be at risk for developing a substance use disorder. We're anticipating, so this is still in progress, this what we're working on right now, but we're anticipating that we're going to need information from a lot of different levels of analysis, right? From all the way from the functioning of brain systems to some of these more life history variables that we've been talking about. And so we anticipate that we can kind of leverage all of those different variables and levels of analysis to try and come up with an accurate prediction. But that's just to point out that, look, to underscore the fact that it's very complicated and there are a lot of different factors that are important to consider.
And I think you're muted
looks like
there.
Looks like I was muted. I would just ask you, Dr. Elgin, if you had anything to add.
No, I mean, I really appreciate Alex's comprehensive answer. I guess I would just highlight, and maybe a little more in line with my expertise, less on the biological side, but also the ways in which people conceptualize substance use and the statements that they make to themselves about the substances that are around them. So we know that what are often called expectancies, but that's really the belief that a substance will have a certain effect. We know that those develop over time, and they grow up often early on with the influence of parents, then more and more due to peers as adolescents age. And these really matter in terms of the extent to which young people think that a substance can help them and the ways that they rely on them. So part of what I think matters for risk is whether young people view a substance as really a good way to cope with different things they encounter in their life, especially a way to cope with negative experiences like anxiety or depression. And the more that they believe that substances are a useful tool to them, again, with a focus more on the negative side, the more that they're likely to evolve into having problematic use and develop more lifelong problems.
Thank you. Thank you both for that. Next question we're going to move on to. We know that some families do have more people on the family tree who had issues with drugs or alcohol, and some families have fewer. Is this similar to families with many people who develop heart disease or diabetes or cancer? Are there specific genes or combinations of genes that we know are important in addiction risk?
Yeah, so there's been a lot of research on familial risk for substance use disorders, and you're right that it does kind of present in a similar way to a lot of other conditions that we look at in the medical literature. And there absolutely do appear to be genes or subsets of genes that do seem to be related to risk for substance use disorders. However, one of the most interesting directions that research in that area seems to be going in is that there used to be a lot of interest in sort of finding individual genetic variants. Can you find the gene for alcohol use disorder or cannabis use disorder or an opioid use disorder, right? And what we're actually finding is that each individual gene on its own, so there are genetic variants that do seem to predispose people, but the effect of each genetic variant on its own is very, very, very small. And what you actually have to do is use models that are called polygenic risk models or polygenic risk scores. And what they'll actually do is sum across many different genetic variants to try and predict an outcome like a substance use disorder with some success. And so we're finding in some ways that this is not necessarily surprising. So even traits like how tall someone is, like height, are actually determined by many, many different genes rather than one. So the field has really kind of changed from a field in which we're looking at individual variants to try and finding these overall patterns of risk. Now, the overall links that are being found between genetic measures and substance use outcomes still are actually pretty modest, and there are a lot of potential reasons for that. One is that the interactions between genes and the experiences that people have are unique for each individual. For example, someone with a high genetic risk for a substance use disorder might be part of a religious community that avoids substances or only uses them in certain contexts, and that could be protective. On the other hand, someone else at high risk might be exposed to a lot of trauma or life stressors or other environmental contexts that are going to kind of interact with their genetic risk in complex ways. So there's a lot of, there's a lot of ways that are at this moment poorly understood with how those genes interact with the environment.
Thanks so much for that. And the next question that we move on to reads, if you know that your family tree includes multiple people who have alcoholism, drug problems, or other kinds of addiction, should you avoid drinking alcohol, smoking, or trying a drug at all?
That's a really great question, and I think it's one that we get a lot in our work. And unfortunately, it's one of those questions that there really isn't an easy answer to, because it depends on a lot of things. It depends on sort of the severity of the difficulties that you're seeing family members experience, but it also has to do with your own decision making and kind of your own personal tolerance for risk, right? So clearly, it's definitely clear that the most effective way to prevent yourself from developing a substance use disorder is to avoid substances altogether. And I think I've met a lot of people, both in life and in working in this field, who have kind of understandably made that personal choice. But there are individual differences, and there's a lot of, there might be a lot of reasons why you might want to use a substance socially. You might be curious about using substances. So if you're kind of personally willing to accept some level of risk and make that choice to try substances, what I would say is that it would probably be a good idea to kind of try and educate yourself on what are the risk factors, what are the symptoms, right? What are some common problems that people can experience when they are using substances, right? Because like Mark said at the beginning, what takes a person's level of substance use or whether they're using substances or not is separate from what we would consider a disorder, right? Which is kind of the negative consequences of that use. So it might be helpful to kind of educate yourself and monitor yourself for symptoms of dependence and for some of those negative consequences happening. And then I would also say that I think the most important thing to keep in mind is that it's okay for you to ask for help if you begin to feel like you need it, right? Mark, do you have anything to add?
I agree with what you said. I was just going to point out that especially when thinking about families with unusually high risk for substance use disorders, it's important to point out that one of our strongest predictors of development of substance use disorder is age of first use. So there is a lot of benefit to thinking about how to delay age of first use. I know sometimes people mention, oh, my kids are going to use anyway, so what's the big deal if they use now versus later? And what the literature tends to show is that there are benefits to pushing that back in time. And it makes sense because the person who isn't using substances is learning a whole set of skills that don't involve substance use that they can employ when they encounter challenges in the future. So this seems to be one of those instances where kicking the can down the road could be a reasonable strategy. The other thing to point out when talking about families who have experience with addiction is I do think it's helpful to be honest about what that history might look like to inform kids that this risk may be particularly high in their family, but to do so in a way that's not stigmatizing and encourages the kids to speak up if they're considering use, if their friends are using, and if they do want to talk about some of the things they're struggling with, if they have used and are maybe struggling to moderate that, making sure they know the door's open to talking about that and having those conversations.
Thank you. Thank you both for those answers. At what age is someone most at risk of developing a drug or alcohol problem? How does that change from the preteen to teen to young adult years?
So what we know from the literature is that most, so again, keeping in mind the distinction that Mark brought up in the beginning, the distinction between the use of substances and kind of the development of a disorder. What we know is that for the most part, substance use initiation for most people normatively actually does happen in adolescence, right? At least for substances like alcohol in high school. So it's most likely that people are kind of first start experimenting from ages around 14 or 15 to age 20. That said, it can take it can take a while for people to start to actually experience negative consequences of disorders. So the peak time in which people are actually exhibiting a substance use disorder is actually a little bit later, sometime in kind of the early to mid 20s is often when that'll kind of onset.
Yeah, and one thing to point out in addition to that is that many individuals will age out of a substance use disorder. So our goal as treatment providers is to help encourage and facilitate that natural process. And we've talked a lot about the disease model, and I personally believe in the disease model and think there are strong benefits to thinking of addiction as a disease. But sometimes you will hear the message that addiction is a chronic and relapsing disease. And this is true for many people with more severe substance use disorders. But it's also true that the vast majority of people who at some point in their lives have a substance use disorder will actually mature out of or transition out of having a substance use disorder completely on their own and without treatment. And so, I think it's a little bit of a dual message. So on one hand, you want to encourage people to reach out for treatment, to have those experiences be as positive as possible. But we don't want to make any statements that in some way denigrate the changes that people make on their own or imply that those aren't also meaningful and impactful.
Yes, thank you. Thank you for that, Dr. Ilgen. For parents concerned about their teens, some may wonder if they could make it safer for their children and their friends by hosting supervised gatherings where they can drink alcohol or use cannabis. Is this a safer option than just trying to hope that your kids will make good choices when they go out to social gatherings and parties outside your home?
Yeah, it's a good question and an interesting topic. I think it's common, especially in places where parents have traveled overseas or know individuals from other countries, to have people say, why don't we just allow kids to have alcohol just like they do in Europe? Maybe if we could make it more of a natural part of the home, it wouldn't feel so stigmatized and maybe they wouldn't get into the same sort of problems. And so I think one point that I think is worth underscoring is that a lot of European countries that have more permissive approaches to childhood and adolescent drinking also have very active drinking cultures and higher rates of alcohol use disorders than we do here in the US. So places like Hungary, Russia, Germany, the UK for binge alcohol use are allow that early use, but also still experience problems. And it's very complicated. There are a lot of layers of cultural influence. And I just think it's important to keep in mind that it is more complicated than just whether someone observes or consumes alcohol, with their parents or in a safe environment. The other point I'd make to maybe that's a little more in line with what you were asking about hosting a party or allowing people to drink, allowing kids to drink safely in the home is it actually builds on a point Alex made earlier that there are these longitudinal studies, some of which have been conducted here at U of M, that look at what are the strongest risk factors for developing a problem. And there's, I think, arguably the largest longitudinal study out there that has been done of teens and adolescents, something called the Monitoring the Future study, and has been conducted at the U of M dating back to the 70s. And they have a variable that's referred to as parental monitoring. And this really gets at the extent to which parents are paying attention and noticing when their kids are doing potentially risky things. And it's not necessarily specific to substance use. It could be just the amount to which kids are able to stay out late at night on a school night, those sorts of things. And the typical finding is that this parental monitoring variable is very protective for substance use disorders. So the questions are not specific to, as you're pointing out, hosting a party, but they do seem to reinforce the idea that instead of more permissiveness, on the flip side, more close paying attention and maybe more cautiousness on the part of parents seem to predict lower likelihood of problems over time. I don't know, Alex, do you have other?
Yeah, no, absolutely. I think that's just really important to reinforce, is that that variable parental monitoring seems to come up in pretty much every data set that it's looked at, right, as one of the biggest predictors of substance use problems, as well as kind of other mental health outcomes as well. We're actually finding that with ADHD symptoms as well in the ABCD study. And so just to monitor, just to highlight that is, it's really a good thing to be monitoring most kids, especially in the case where, to your earlier question, if you have concerns about a family history of substance use, right, it's especially important to kind of be curious and be open with your kids about what they're doing, and be asking questions.
Thank you both for that. We've talked a lot about younger people, but is it still possible for problems to start later in life? Are there life events that are especially linked to new substance use issues?
Yeah, it's a good question. I think that the short answer to it is yes. Substance use disorders can develop at any time in life. As we discussed earlier, the most common age of onset is in early 20s. So that would be the average age, but there's certainly a lot of instances where they occur outside of that. Often it's in response to a new situation or new stressor, things like divorce, needing to move, even things that could seem like positive events like retirement can change the ways in which people use substances, as well as the problems that they experience. So we've seen this with COVID and what's happened to substance use since the onset of the pandemic. The data are still a little murky at this stage, but from what we can tell, amounts of substance use did increase with COVID, especially alcohol and in all likelihood marijuana use. And for some people, that increase in use led to more problems. It also changed the context in which people used. So people were less likely to use in large social gatherings, and it probably reflected more use alone, maybe more use to cope with stress, to sleep, other types of use behaviors that tend to be predictive of onset of problems. So we're just starting to see the data on how this looks in our population, and there is an indication that there's an increase in problems. And I'm guessing that will, we're probably on the front end of that curve, given the relationship between just use patterns and then development of problems. It may be that we'll see more and more of that over time.
Thank you for that, Dr. Ilgen. Let's talk about the relative risks of different substances. Are alcohol or cannabis as addictive, so to speak, as prescription painkillers or cocaine or methamphetamine?
Yeah, this is a topic that comes up a lot, especially you hear it around marijuana with the move towards legalization in many states, including Michigan. And there are a lot of different ways to think about risk associated with substances and then how that compares across substances. So, I think it's easiest to think of short-term and long-term risks. For short-term risks, we know that consumption of many substances can lead to the slowing of respiration or cardiac arrest. And so someone can die by an overdose with using. And there, you can pretty easily line up substances against one another and come up with a clear indication of which substances are most risky for overdose and death. As I'm sure people are aware, with the attention that's received in the media, fentanyl is one substance that where it doesn't require much quantity in order to get a strong negative response and even have fatalities. And fentanyl is finding its way into a lot of different substances, certainly opioids, but now even stimulants are sometimes laced by fentanyl. And so this is why in treatment, we really emphasize the importance of patients and their loved ones having access to Narcan or naloxone and medications that can reverse the effects of an opioid and reduce the likelihood of an overdose. So that's talking about short-term risk. I think we could say, yeah, we can come up with a hierarchy there around substances. It's a little more complicated when you think about long-term risk, and it's just harder to study. There have been a few longitudinal studies that will track, for example, the progression from first use of a substance to development of a substance use disorder. And you can create these curves and figure out which ones seem to progress most quickly from first use to the disorder, as well as what substance has the highest percentage of people that use it that go on to have a substance use disorder. And when you do that type of work, the consistent winner or loser, depending on how you scale your item in that horse race for risk, is usually nicotine. So the percent of people who first use nicotine who go on to develop a nicotine use disorder is the highest of all substances. And when you look at what's on the lower end, cannabis or marijuana tends to be one of the lower risk substances there. Anywhere between 8 and 10% of people who use cannabis at all will develop a cannabis use disorder. However, to complicate things further, the picture changes a bit when you just look at people who are currently using and the extent to which frequency of use matters as a predictor. And it's harder just because of the way these studies are designed to lay substances up next to each other. But one thing to point out with a substance like cannabis is that, yes, a low percentage of people who ever use cannabis go on to develop cannabis use disorder. Those who are using it regularly are actually pretty likely to develop a cannabis use disorder. So there's a nice Dutch study that follows people who use cannabis 3 times a week, and they find that over 30% end up with a cannabis use disorder within 3 years. And within our data here in Michigan, studies we've done of medical cannabis users, the rates of cannabis use disorder among those patients, many of whom use daily or multiple times per day, they're in the 50 to 60% range. So if you're using at a high enough frequency, even though there's this kind of average sense that cannabis is less problematic, it still can be associated with problems, and even in the majority of people if they're using frequently enough.
Thank you for that, Dr. Ilgen. We have an audience question now. We have an interesting insight from an audience member that I wonder if you can react to. We've been talking mainly about addiction to substances such as drugs and alcohol, but one can be addicted to food or gambling as well, correct? How do those differ, or do they?
Yeah, so this is a really great question. And it actually has to do with a really interesting, basically controversial in kind of the broader fields of clinical psychology and psychiatry, which is how to think about with what these are so-called kind of behavioral addictions, right? And so one thing to keep in mind is that kind of, again, tying back to Mark's kind of first introduction of this concept in the beginning, when we think about a disorder, it's really just kind of a label for something that helps us as professionals kind of have a good language for it. And when we talk about a substance use disorder, we really think about, quantity of substance, but also, is this causing problems for you? Are you, using the substance so frequently that you're not able to meet other commitments for your family or for work, or that you're not doing other things that you used to enjoy, right? And you can see how, addiction to the concept of addiction to other things other than substances, right, can fit into that pattern, right? If you're kind of consistently doing something and having basically problems associated with use. There's also been an interest in the neuroscience literature in trying to find, are the neural correlates of these other use disorders, can they actually be similar? And in some ways, in some cases they often are, right? So you can see that, neural areas of the brain that basically respond to rewards kind of have similar responses to drug rewards and non-drug rewards in individuals who might have, for example, a problem with eating, right? And so there's a lot of areas for overlap, but one thing to just keep in mind is that to keep in mind that the concept of addiction, the concept of substance use disorder, it's not black or white, and it really is just kind of related to, it becomes more about a conversation of how can we address these issues, right? Rather than necessarily identifying this as like a distinctive disease or condition. So that's my initial thoughts on it. And I would say that it's a pretty, like I said, it's kind of an ongoing controversy in the field. I'm curious what you've heard, Mark, and what you think about it as well.
Yeah, I agree. It's one of those topic areas where there is a lot of active debate. I truthfully, I have some mixed feelings about it, because I think we can learn a lot from what we've learned about substance use and apply that to a topic area like, let's say, gambling addiction. And in that instance, a lot of the treatments and approaches that work for drug use disorders can work reasonably well in that patient population. So I think it's helpful to look for the shared similarities between those. It also, there are times when people use the term addiction casually, and it can, I think, cheapen or undercut a little bit the perceived severity of substance use disorders. They might say, I was addicted to chocolate, but I was able to change that. Why can't someone change the way they use alcohol? I mean, probably someone wouldn't say that directly, but that's what's implied. And so, I think we can learn things about behavioral addictions, as Alex is pointing out, from what we know of decades of research on substance use disorders. But there are other ways that substances directly target the neurotransmitters in the brain that lead to some of these repetitive behaviors. And, especially when you're getting into drugs like stimulants, opioids, that are just hitting those receptors directly without much getting in the way, there's a degree to which that addiction is different and more intense than what people experience with other behavioral addictions.
Yeah, I would agree with that. It's probably best to view it as, we can learn things about, the causes and the treatment of these disorders by kind of referencing the addiction literature, but it is worthwhile kind of thinking about ways in which it's different. That's a great point.
Yeah, thank you both for your answer to that audience question. The next question that we have surrounds the phrase gateway drugs. We often hear about certain substances referred to as gateway drugs that perhaps set someone off on a path to future problems. Is this still a valid concept, or is it more about the person's underlying vulnerability than what substance they decide to use?
Yeah, so I think that this idea of gateway drugs has been so persistent, in part because statistically speaking, it's definitely true that one of the best predictors of future substance use and future problems with substance use is past use of any substance, right? So this term has been used a lot in talking about cannabis, but it's interesting. There's some findings from recent studies looking at large data sets, trying to find different predictors of substance use, have found that, for example, smoking, right? So there was one interesting finding where they had a lot of different predictor variables, and they were looking at what was, which ones basically predicted problematic alcohol use in teens. And what they actually found was by far the biggest predictor was whether or not a teen had actually tried cigarettes around age 14 was a big predictor about whether they were binge drinking at age 16, right? So it's used a lot in cannabis, but it is true that in the statistical sense, the idea of gateway drugs clearly has some validity to it. The problem is that sorting out whether that relationship reflects a direct causal effect, they tried smoking or they tried cannabis and therefore they moved on to other substances, is really difficult because, like you said, a person's underlying vulnerability might have made it likely that they would have tried both substances, right? There might be other examples of what we would call in research third variables. So things that are that might cause a substance use disorder later that also cause some individual to try substance earlier, right? So maybe some substances are available in the kind of family or community context for someone, whereas they aren't for someone else. So it's really hard to kind of suss out what that relationship, what the relationship is. Mark, do you have any thoughts on that?
No, I pretty much agree. I think the term gateway drug is so strongly associated with the kind of reefer madness or messaging around cannabis that seemed overly negative and really turned people off from the late 70s through late 80s that was out there. I think that it's not used very often in the scientific literature, and it's something I certainly try to avoid using when talking to parents or patients, because I think it just kind of, people have a knee-jerk reaction to it. And as Alex is pointing out, there's probably some truth to it. There in the opioid literature, there's a lot of it's pretty likely that people progress, or many people progress from using prescription opioids as prescribed to then maybe taking them a bit as they're not prescribed, to then maybe trying another opioid like smoking heroin, to then moving to injecting a drug. So these progressions can occur, and they can build on each other. But I think we often don't refer to them as gateway drugs just because that's a good way to lose your audience, I think.
Yeah, thank you both for that insight. Could you comment on something that research has shown, which is that people with conditions such as depression, anxiety, post-traumatic stress disorder, or schizophrenia are more likely to have substance use issues? Why might that be?
Yeah, so in terms of coming from the perspective of genetic or biological risk factors, one of the most interesting trends that we're seeing, I think, in research recently is that we're finding that risk factors for mental health conditions, including substance use disorders, tend to be fairly general. And by that, I mean that genetic variants, and so like I said before, there are kind of small effects of a lot of different variants that seem to affect risk for substance use disorders. But what we're finding is that those variants that seem to be related to substance use disorders are often the same genetic variants that have weak relations to the development of things like schizophrenia, ADHD, or even depression. And so, like I said, these are kind of weak relationships at the level of individual genetic variations. But when you take polygenic risk scores or polygenic risk models that sum across these variants and look at risk for some of those other disorders, you tend to find that those scores also correlate with problems with substance use. But I think it's something that's important to keep in mind is that not only at the level of genetic risk, and it's maybe something that Mark can kind of talk a little bit more detail about, is that there's some really important dynamic processes that can happen in which an individual with a separate mental health condition can then also develop a substance use disorder.
Yeah, and I think on the psychosocial side, the belief that you need a substance to cope with a symptom, especially a powerful symptom like depression or anxiety, can lead to the onset of substance use disorders. That link is not as strong in the literature, but certainly there is a link between self-medication or using a substance to cope and perpetuation of the substance use disorder. So for those people who have already developed a substance use disorder and still feel that the substance they're using is key to them coping with their past trauma, their feelings of anxiety, those folks have a much harder time changing their substance use. And I think that provides a window of opportunity for treatment to be more helpful. There used to be the message in drug and alcohol treatment that you really need to focus on your addiction, and that's all you should be doing when you're seeking substance use disorder treatment. And I think the model has really changed, and it's certainly something we try to do differently at U of M, and that is talk to people about what are those factors that motivate their use, and how can we help them cope with those symptoms or experiences better. So in some cases with depression or anxiety or sleep problems, you might be looking at medications to help address those issues. And then we're simultaneously looking at some of those expectancies, what people are telling themselves that they need the substance for, and helping them develop alternative ways of getting through a hard time that don't rely on substances.
Thank you both for those answers there. Next question we have up, and just to note, we have about 7 minutes left of this. We're getting through the questions thick and fast, and they're coming in pretty quickly too. The next question we have says, is it hard for a person to understand that they have a problem when they really do have a problem? Why is that? What are some of the warning signs that they or others who love them should be looking out for that should prompt them to seek help?
So one thing that's really important to keep in mind about this is that many people who have substance use disorders who haven't sought treatment yet, and even a lot of people who are seeking help, often feel highly ambivalent about the problems that they're experiencing. So basically, it's very common that people might recognize the negative consequences of substance use and even have a desire to prevent these consequences. But that desire also is naturally going to conflict with other feelings that they have. Things like, enjoying using a substance, seeing using a certain substance as a part of their identity, and also oftentimes, like Mark was talking about in terms of using substances to cope with things like anxiety, it could be really, really scary for someone to think about, well, I have all these problems related to alcohol, but I don't know how I'm going to get through my day or get through the next kind of social situation, that gives me anxiety without it, right? And so you often see a lot of these kind of conflicting thoughts, conflicting desires in people. And the goal for us as treatment providers, and I also think for family members, is to kind of meet them where they're at in a non-judgmental way. So if you see that somebody is having problems and that might be aware of some of them to some extent, one of the best things that you can do is actually just try and have a non-judgmental, open-ended conversation with them about their use. Just kind of introduce the topic and say, I noticed that you've been using this a lot. Can you tell me a little bit about that? And then if they identify problems that they're having themselves, which oftentimes they will, again, they're often aware of these things, this is a really great opportunity for you to then jump in and kind of let them know that you're concerned as well, and that you're there for them, and that you can you're there to help them get help if that's needed. So that's kind of what I would say about that, is that it's often there's a lot of ambivalence, and you can kind of be the person that lets them know that it's okay to kind of talk about those issues and to seek help.
And I'd say that for family members and treatment providers, you need to understand that motivation or desire to change is going to fluctuate over time. When I started, doing my training and working in this field, there was a lot of focus on motivation. How motivated were people? How do we get them more motivated? And there's still, those things are important, but I think there's more now of a realistic sense that your motivation right now is going to fluctuate. It might be wherever it is today at this moment, but tonight it might be here, tomorrow it might be lower. And instead of waiting until the person seems really motivated or the ambivalence seems to have gone away, what you really want to do is just try to help people start making changes and reaching out, no matter how they're feeling in the moment. And this is the way a lot of behavioral treatments work, is that it's tempting to wait until the stars align before making changes, but we know that actually it's better to just try little things, and some of those tend to work a little bit, and you do them a little more, and then it kind of snowballs. And so, I think a lot of what we're trying to do as treatment providers is understand what sort of thoughts are people having around their sense of ambiguity or sense of uncertainty about changing, and then how can we reinforce those that encourage change and help people make some of those changes, even if they're still on the fence about what they want to do ultimately or for the rest of their lives related to the substance.
Thank you both. Let's move on to a couple of questions for people who are worried about someone's substance use right now, or they are worried about their own use. What are some specific steps that they can take to get help for themselves or others?
Yeah, so the one important thing is to, as Mark mentioned, is kind of like think about it. Don't not necessarily wait till the stars align for to actually ask about getting help, but you can kind of introduce the idea of getting help in kind of a non-judgmental way. And so it's fine to kind of express concern in a way that isn't necessarily shaming to an individual. And then once an individual has some buy-in, kind of like shows that they are ready and they do want to start talking about reducing or stopping the use of a substance, it can really help to then develop a concrete plan. And what you can do to facilitate that is actually research treatment options beforehand. So there's one really great resource for this is a US government website called findtreatment.gov. This can kind of give you an idea of what treatments are available, the logistics of how to actually get in-person treatment. And then it would also be good to know that not all treatment is necessarily going to rehab, going to an inpatient residential treatment. There's a huge gradation in terms of different treatments at the inpatient and outpatient level. And there's also a huge variety of treatments that may or may not work for different individuals. So there's a lot of different options.
Thanks. Oh no, go ahead, Mark. Dr. Ilgen.
No, I was just going to say, one factor I think is that it's important for family members or friends and loved ones to keep in mind is choosing the right time to have this conversation. I think it's tempting, especially if you yourself are experiencing frustration, that you just kind of dive in when that frustration is at its high point for you. And that's not necessarily the time when it's best to engage the person that you're talking to. So, it may make sense to wait until the person is feeling better. If they were impaired or hungover or something, you catch them at a time where they can hear the message. And as Alex is pointing out, really talk behaviorally about what it might look like for them to make changes and help them reach out and know that the options are not as scary as they may sound if you've just only heard of 30 days of residential treatment is the only version of rehab. There are a lot of things out there, including medications, focusing on the other condition like depression, that actually help people feel better and can fit in their lives and are often good options for people. They don't work for everyone, but there's really a whole menu of options available that people could choose that are less daunting than some of the things that are out there in popular culture.
Thanks. Thank you both. Now, as we hit the top of the hour, before I let you go and I say thank you to our viewers, I always want to ask, is there anything you think we've missed? Do you have any final thoughts or anything like that? Dr. Weigard?
Yeah, I think we've covered a lot of ground here in this conversation, and I think I would just reiterate that there are a lot of, like Mark just said, there are a lot of treatment options out there, and it's really important to just consider how kind of like popular conceptions of treatment might kind of be negatively impacting people's willingness to seek help, or even popular conceptions of substance use disorders, like we talked at the beginning about stigma associated with things like alcoholism and substance abuse. So just kind of being sensitive to that, and help kind of educate, learning more yourself and helping someone you're concerned about learn more about the huge plethora of options that's available, and the fact that help is out there, and that they should have hope, because the vast majority of people, like we said, do end up recovering, whether it's through an official kind of a formal treatment program or on their own.
Yeah, and I'd agree with that. And I think another similar message is that, yes, there are a lot of treatment options out there. There are a lot of good ways to support and help people. But you, either as a loved one or maybe someone who's concerned about your substance use, you don't need to know what all of those are or feel like you need to have the perfect roadmap to a solution in order to reach out for help. I mean, we don't do that for people if they are going to go see a cardiologist. They don't feel like they need to know what treatment they're going to receive in order to make that initial call. And the same is true for addiction treatment. I mean, one of the things we do at U of M when someone comes in is the first session or two is really focused on understanding the problem, understanding the preferences of the patient, and then helping them come up with a plan that they're comfortable with and we think is going to maximize the likelihood of success. And so, you can put some of that on the treatment team. You can make, especially if you make that first call, then they can give you their recommendations and they can help lead it from there, and hopefully help support you in making whatever changes you want to make.
Thank you both. Very powerful final thoughts there. And thank you again to everyone for joining us today as we mark Mental Health Awareness Month. If you'd like to share this video with anyone, you'll be able to find it on our Michigan Medicine YouTube channel and Facebook page at any time. You can see other upcoming live streams at medicine.umich.edu/DEPT/psychiatry/events. That's medicine.umich.edu/DEPT/psychiatry/events. If you or someone you know is in need of substance use treatment, you can start at the national website, findtreatment.gov, or you can start with our team at the University of Michigan Addiction Treatment Services. Their website is umaddictioncenter.org/clinical-care. That's umaddictioncenter.org/clinical-care. Or you can also call 734-764-0231. That's 734-764-0231. We appreciate our experts' help with today's chat. Dr. Ilgen, Dr. Weigard, thank you for sharing your time and expertise with us. And we hope you all have a good week. Thank you.